Pulmonary thrombectomy requires safe passage of a catheter through the right heart into the pulmonary artery. Familiarity with relevant anatomy and technique can increase the likelihood of successful catheterization and reduce chance of cardiac injury. This animation demonstrates to Inari operators the preferred method of crossing a dilated right heart safely to avoid entanglement in cardiac structures, specifically the chordae tendineae. Inari Medical recommends two different methods for crossing the right heart during a flow Triever mechanical thrombectomy procedure for the treatment of pulmonary embolism. The preferred method for crossing the right heart is with a balloon-tipped catheter or pulmonary wedge catheter, PWC. A 7 French catheter with 0.035-inch lumen is recommended. This catheter should be advanced through the venous sheath, then the balloon can be inflated. The balloon tip will act as a sail and, when advanced, will preferentially travel with the direction of blood flow. Additionally, it provides a high level of safety when deflecting off intracardiac surfaces. The catheter should be advanced to the right atrium, then rotated until it points towards the right of the screen. Advancement at that point usually directs the catheter down through the tricuspid valve. Once the catheter reaches the right ventricle, a quarter to half turn clockwise will direct the balloon tip upward towards the right ventricular outflow tract, RVOT. Advancement of the catheter, timed with favorable catheter orientation, should facilitate passage through the pulmonic valve into the main pulmonary artery. The morphology of the hemodynamic waveforms can be used to confirm tip location as the catheter tracks through the RA, RV, RVOT, and finally into the main pulmonary artery. Care must be taken to avoid advancement of the catheter into alternate locations, including into the left atrium and pulmonary veins, across a patent foramen ovale, or ASD, or coronary sinus. Tortuous anatomy and right ventricular enlargement are extremely common in patients diagnosed with intermediate high risk and high risk pulmonary embolism. Additional techniques may be required to successfully cross the right heart of these patients. The reverse curve technique can be employed if the catheter cannot be directed downward through the tricuspid valve, or if it cannot be oriented upward to the RVOT. It is achieved by orienting the balloon-tipped catheter to the left side of the screen when in the right atrium. Deflection off the right atrial free wall will create a loop with favorable orientation to then pass through the tricuspid and pulmonic valves. Once the balloon catheter has been advanced to the pulmonary artery, gentle retraction of the catheter will reduce the redundant loop in the right atrium, creating a straighter path for subsequent wire insertion. An alternative approach to creating a reverse curve is the liver snag. Starting in the IVC, the balloon catheter is oriented to the left of the screen and advanced until it enters the hepatic vein. Once several centimeters of catheter have entered the hepatic vein, continuous catheter advancement will create a knuckle that enters the right atrium. The catheter tip is then disengaged from the hepatic vein with slight rotation and retraction. The catheter will then be positioned similarly to the reverse curve, which will be favorable for passage into the pulmonary artery. The double balloon technique can be used as an adjunct to any of the above crossing methods. It is performed by overinflating the balloon tip from 1.5 to 3 cc's. The larger balloon size will serve as a larger sail to float along with native blood flow and to deflect off intracardiac surfaces. The other method for crossing the right heart safely is with the use of a fully formed pigtail catheter. This technique utilizes the back end of a guide wire that can be custom shaped to accommodate the dilation of a right heart. This provides increased stiffness for torqueability and a favorable shape to direct the catheter while retaining the safety of a soft pigtail tip that will not entangle with the chordae tendineae. The larger the right ventricle, the greater the curve on the wire. It is important to keep the wire from advancing too far into the catheter to avoid straightening of the pigtail or wire advancement beyond the tip. Rotate the catheter until it points to the right of the screen, then advance the pigtail towards the right ventricle. Upon reaching the right ventricle, a quarter to half turn counterclockwise will orient the pigtail towards the right ventricular outflow tract. Advancement at this point will direct the catheter successfully into the pulmonary artery. Upon a successful cross of the right heart into the pulmonary arteries, the operator is now able to take PA pressures, perform a PA angiogram, and has established a safe pathway for the advancement of ancillary wires, catheters, including the Triever catheters. There should not be resistance when advancing the Triever catheter. If resistance is met, immediately stop the procedure and reassess. Patients with baseline left bundle branch block, not supported with a pacemaker, may experience complete heart block when crossing the right heart. If wire purchase is lost, the operator should attempt to cross the right heart with the balloon tip catheter as outlined in Step 1.